Good morning. I'm Fiona Hegi-Johnson. I'm one of the three co-chairs of World Lung Congress this year, and I'm a radiation oncologist at Peter Mac, which is a cancer centre in Melbourne, and I'm also an academic at the University of Melbourne. And I'm very excited to moderate this press briefing, which will feature a full spectrum of presentations, including a presentation from my rad-onc colleague, Dr. Stephen Chun, on the NRG Oncology-RTOG 0617 study. It's a very important study for our craft group. And additionally, we will hear from a patient advocate, Dusty Donaldson, who has decided to address one of her country's biggest lung cancer research problems, underfunding, and I think we can all relate to that issue. I'm also looking forward to hearing from Dr. Tetsuya Mitsudomi, who's going to give an update on the AEGEAN trial, and he's going to present data examining associations between sex-specific reproductive factors and the risk for lung cancer among women. And this is a very compelling line of research and very novel, which is being presented here today by Dr. Zhang, and this may help us better understand the uptick in lung cancer cases among women who have few risk factors, which is a key problem in this region. And as my friend Dr. Stiles and Dr. Naidu mentioned earlier this week, we are really unique in including our patients in our conferences and press briefings. And today we are very, very fortunate to have actress and writer Annabelle Gurwitch, who's going to try and summarize this morning's research from a patient's perspective, which is just invaluable. So without much further ado, I might ask Dr. Zhang to start.
Good morning, everyone. I'm to be honored to be here to share my work today. It's about association between women-specific reproductive factors and the risk of lung cancer. In 2020, more than 2.2 million new cases of lung cancer and 1.8 million deaths were estimated by GlobalCan. In contrast to the majority of male patients with a history of smoking who have more subtypes of non-squamous cell lung cancer, women who have never smoked were more likely to develop a subtype of adenocarcinoma. Female non-smokers were approximately 3 times more susceptible to developing lung cancer than male non-smokers. Risk factors other than smoking and pollution have not been thoroughly identified, especially among women. Hormonal and reproductive factors were thought to be involved in the development of lung cancer in women. However, these findings have been far from consistent across the study. That's why we did this investigation. It was based on the data of female from UK Biobank, and multiple reproductive factors were estimated, and the lung cancer was the endpoint, and we use multiple analysis to do this investigation. The baseline character about the participants among 273,190 patients were enrolled in the study, and the women with incident lung cancer were older, less educated, and were more likely to be current smoker. In terms of reproductive factors, those women with incident lung cancer were accompanied by an earlier age at menarche and menopause, a short reproductive span, and an earlier age at first live birth, as well as a lower likelihood of oral contraceptive pills use and a greater exposure to hormonal replacement therapy. The results parts from the RCS, they show the linear relationships between the menarche and the menopause-related factors and the risk of lung cancer, along with the hazard ratio, reveal that the early menarche, especially the age younger than 11 years old, and the early menopause younger than 49 years old, and a shortened reproductive factor less than 35 years old, were associated with elevated risk of lung cancer. For the parity-related factors, we also identified the early age and the first live births were associated with the increased risk of lung cancer in linear relationships, but the number of children, miscarriage, and stillbirths and abortion were not. For the hormonal dysfunction, we also identified the history of oophorectomy as a risk factor, but hysterectomy, HRT, OCP were not. The subgroup analysis showed that these multiple reproductive factors have great effects in subpopulations with baseline age less than 60 years old, previous or current smokers, higher genetic risk, and especially for the incidence of non-small cell lung cancer. We also did several sensitivity analyses, including removing the participants with hysterectomy or oophorectomy to reduce the effect caused by artificial menopause, and also imputed for missing data using MICE methods, and also excluded incident events within the second and the fifth years of follow-up to reduce the possibility of reverse causality. We also compared individual and combined associations between reproductive factors and the lung cancer. They all yielded similar results and confirmed the stability of our main findings. In the past decades, several studies show try to figure out the relationships between the risk of reproductive factors and risk of lung cancer. As shown in this table, they have been far from consistent. We thought the heterogeneity of the study design, sample sizes, duration of follow-up, and other unmeasured factors may be explained for such a discrepancy. There are several strengths of our study, including a large sample sizes of this prospective cohort study within 10 years more than 10 years follow-up. And we are also the first to incorporate genetic susceptibility for stratification, and we also choose an appropriate population consistent with relatively normal physiology as a reference, not the extremely cases, to avoid some potential bias. There are also some limitations for the study. There may be some measurement bias and misclassification for the self-reported reproductive factors. Second, we also only included the females of European ancestry, perhaps limiting the interpretation and validation of the finding into other populations. Third, most women who had undergone oophorectomy or hysterectomy were also given HRT, so it was very difficult to attribute the effect caused by individual factors. Some other unmeasured confounding factors, such as outdoor and indoor air pollution or healthy bias of the population. Thank you for your attention.
Thank you so much. So our next presenter is Dusty Donaldson, and I'll give a brief introduction to Dusty. Dusty is the founder and executive director of the Dusty Joy Foundation, or Live Lung. She is also co-chair of the Lung Cancer Action Network, which is a collaborative association of lung cancer nonprofit organizations and patient advocacy groups. In 2016, she co-authored the book, The ABCs of Lung Cancer for Patients and Advocates. She's working on the second edition, which is going to be released soon. And she's a reviewer for lung cancer research proposals for ASCO's Conquer Cancer Foundation and the congressionally directed medial research program's Lung Cancer Research Program. She's a contributing writer for lungcancer.net and serves on the National Lung Cancer Roundtable Survivorship, Stigma, and Nihilism Task Group. In 2022, she received the IASLC Patient Advocate Education Award. And prior to being diagnosed with early-stage lung cancer in 2005, Dusty was a journalist and a public relations professional, and she's earned her place with undergraduate and graduate degrees in journalism. So thank you so much, Dusty.
Thank you very much. I hope you can all hear me now. So this project, I just love it, and it's so exciting to me, and I hope we can do more and build on this. But I wanted to tell you, just to lay a little groundwork for those of you who might not know, the Lung Cancer Action Network, or LungCAN, it's an association of a collaborative association of leading lung cancer organizations and patient groups, biomarker groups and such. And we have a mission to unite and to amplify the voice of the lung cancer community. So there are a lot of different, institutions, organizations, but we came together for this particular cause, which was, of course, to increase lung cancer research funding. And then I'm going to get into the actual program. The Department of Defense in the US, we've got, under the Department of Defense, there's this congressionally directed medical research program that funds all types of research for all types of diseases, maybe not all types, but many, many types of diseases. And we, in 2009, were successful in, I say we, the lung cancer community was successful in getting a program for lung cancer research funding under the DoD. It's called the Lung Cancer Research Program. So that program started in 2009 at the $20 million level. And as you can see by this chart, a lot of times programs just increase, they get more funding year after year, but we, in fact, were seriously impeded, and we did, ours was reduced significantly. It got down to just a little over $10 million over the years. And so as the advocate community, we kept trying to just get the 20 million restored. And if you take into, consideration the inflation rate, I mean, we're really behind the 8 ball here on funding for lung cancer research. And let me mention the lung cancer research program under the CDMRP is the second largest funder of lung cancer research in the US. So this is a pretty big deal, second only to the NCI. So we were finally successful. The whole lung cancer community was successful in advocating to get the $20 million restored in 2021. And then we hung steady in 2022. But we were all, very frustrated with that amount. And I want to just put things in perspective, not to pit one cancer against the next, but we all know in this room the disparity in funding for different types of cancer. And so this chart illustrates the funding per death of different cancer types. Now, the CDMRP has a breast cancer research program, and that is an amazing program. It's done wonderful things for the breast cancer community. But when you see the stack of bills against the number of deaths from the breast cancer, you can see the disparity. Same with prostate cancer. The amount of money that goes into prostate cancer research, the CDMRP has a prostate research program. And then when you compare that to the lung cancer deaths, and the deaths are overshadowed by the stack of money that we get for research. So there's a great disparity. And so we just wanted to, if there is a pie, we just say we need a greater slice of that pie. It's justified in asking for that. So what LungCan did in 2021 was we got together early in the year, and we were led by Jill Morningstar, who she's a patient advocate, but her experience, her professional career was working on Capitol Hill. She worked on the Senate side, and she had advocates coming to her to ask for funding for, their different medical issues and so on. And then her husband got diagnosed with stage 4 lung cancer. Her husband, Al Fitzpaine, who also works on Capitol Hill, and they were kind of blown away, like many of us who are not, we don't choose to come into lung cancer, but we get a lung cancer diagnosis, or a family member does, and then we're in it, and we're shocked by the statistics and the lack of funding. So Jill couldn't understand why there was not more funding and why the people weren't beating down the doors of the, congressional representatives. But she contacted me and said, we need help. Can you, LungCan, help us? And so absolutely, I felt like we had really a catalyst to get started with this. So we developed a steering committee. Every member organization from LungCan could be on the steering committee if they wanted to. It was a little large, but we worked together. We met weekly and we tried to hash out how to come up with an appropriate, reasonable, but justifiable ask, because we felt like we need 100 million, but we thought that was, in this political environment that we were in the US, that might be an overreach. And so some of the, Heidi and Pierre Onda, you might know them from the White Ribbon Project. They were on the steering committee, and they did research, and others did as well. And they came up with this $60 million ask, which we had been, like I said, at 20 million. So we were asking for 60 million, and it was justifiable because if the proposals that were rated outstanding or excellent, if we had been able to fund those, then it would have taken $60 million. Instead, unfortunately, most of the programs that were the highest rated, they ended up in the trash can. So that's why we landed on $60 million. It was a bipartisan effort, and we had people working from all the organizations, from just individuals and as well as organizations. So we fell far short from our goal of 60 million. However, we were really, after we licked our wounds and realized, we're not getting the 60 million, then we realized, this is a 25% increase, and $5 million is nothing to sneeze at. So we were encouraged by that. And now for next year, it's also proposed to have that 25 million in there again. We kind of blew up the internet with this campaign. We just had so many organizations and individuals with Facebook memes and just all kinds of things. We had built a platform to promote for people to contact their congressmen and senators. We had, 1,847 individuals participated in the campaign, reaching more than 400 legislators. And then we had 5,500, because every individual had 2 senators, 1 congressman, congresswoman, or representative. So ended up with 5,500 requests, emails sent to them. And that was just through LungCan platform. And then there were additional 4,000 that came through the Go To Lung Cancer Foundation and Longevity's foundation platform. The Dear Colleague letter, that's just letters to members of Congress from a member of Congress, that had more co-signers than ever before in the House side. And we had a phenomenal support from the Senate side also for the first time, really. But maybe even more importantly, the campaign grew beyond the lung cancer community to the more general organizations. We had so many organizations like Burn Pits and the Hero Veterans Center and all kinds of cancer centers and associations. And it was just a really, everyone just seemed to get behind us. And I'm hopeful that we will continue to increase this, and maybe who knows, next time we might get our 60 million, but thank you very much for the opportunity.
Thank you so much, Dusty. That was just such an inspiring presentation, and really keep up the good work. You guys are just amazing. If you've attended a World Congress on Lung Cancer before, I'm sure you've had the pleasure of hearing data presented by one of the world's leading researchers and advocates, Dr. Tetsuya Mitsudomi. Dr. Mitsudomi is a specially appointed professor, Kindai Hospital Global Research Alliance Center and Thoracic Surgery, Kindai University, Osaka, Japan. And his research interests include the surgical management of lung cancer and targeted therapy and immunotherapy for lung cancer. And in this field, his group has published several papers on resistance mechanisms of EGFR, MET, KRAS, and HER2 mutation-driven cancers. And recently, he was active in developing perioperative therapy of resectable non-small lung cancer, which is really transformative work. He has published more than 400 articles in international peer-reviewed journals. He served as president of the IASLC from 2019 to 2021, is a member of AACR, ASCO, and ESMO, president of the Japanese Lung Cancer Society from 2014 to 18, and he is now an emeritus member of the Japan Lung Cancer Society, Japanese Cancer Association, Japanese Association of Chest Surgery, and the Japanese Society for Medical Oncology. It's an enormous privilege to welcome you here.
Thank you very much. Very kind introduction. And good morning. So I'd like to present the surgical outcomes of the AEGEAN trial. So this is funding disclosure. So the surgery is, of course, the cornerstone of the treatment of early lung cancer, but even with the curative resection, many patients have developed recurrence. So many additional drug therapies are needed. In the metastatic disease, the introduction of the immunotherapy revolutionized the treatment paradigm. So that was now being applied to the earlier disease. So the many trials are actively, already some of the trials are presented and showing the very positive results. And AEGEAN is one such trial. AEGEAN is a randomized control study. The control experimental arm consists of Durvalumab, which is PD-L1 inhibitor, plus chemotherapy for 4 cycles, followed by surgery. Then after that, adjuvant Durvalumab is also administered for 1 year. The control arm is neoadjuvant chemotherapy, so chemotherapy followed by surgery, and then the placebo was administered. The eligible patients were resectable non-small cell lung cancer with stage 2A to 3B with N2 disease, and primary endpoint was PCR, which is a pathological complete response, and also event-free survival EFS. And this primary results already presented in the April of this year by Dr. Heymark and Emily Anderson. So the EFS hazard ratio is 0.68, and PCR rate was 17.2% versus 1.3%. So in the efficacy-wise, it's clearly positive. So my task today, yesterday and today, is to show the surgical outcomes of this AEGEAN trial. So this is the randomization. So of the 366 assigned to the Durval arm, 80.6% and 80.7% in the placebo arm underwent surgery. Underwent surgery means curative intent treatment was attempted. Then of them, 77.6% and 76.7% completed. So completing surgery means that patient have their tumor resected. So about 20% of the patients are not able to be their tumor resected. The reason for not undergoing surgery is most common one is progressive disease of the cancer. So let me show you the comparison of the approach type and the resection status. Approach, about half were open procedure, about half were minimal invasive procedure. For the surgical procedure, mostly lobectomy, and a little bit less than 10% were patients underwent pneumonectomy. And for the resection status, meaning R0 resection, meaning that no remnant tumor behind. So the more than 90% of the patients underwent R0 resection. And numerically, the 94 versus 90 was numerically a higher number of the patients received R0 resection in the Durvalumab arm. And this is the timelines, the time from the last neoadjuvant dose to surgery and time from the surgery to adjuvant. First adjuvant dose is very similar between the 2 arms. And this is surgical day, which was defined surgery requiring more than 40 days after the last neoadjuvant dose. That's very similar. Also, adverse events, I made some mistakes. So this graph is a bit wrong, but AE incidence is not so different again between the 2 arms. So the conclusion is the efficacy was efficacy results were presented, but I showed today that the neoadjuvant Durvalumab plus neoadjuvant chemotherapy plus surgery, followed by adjuvant Durvalumab did not adversely impact the feasibility type approach timing of surgery and resulted in numerical higher R0 resection rate. Also, this regimen had a manageable surgical safety profile. So in conclusion, this clinically meaningful improvement in efficacy, no adverse impact or surgical outcomes, and manageable safety profile. The addition of perioperative Durvalumab. Perioperative means pre and post to neoadjuvant chemotherapy is a potential new treatment option for patients with resectable non-small cell lung cancers. And thank you very much.
So our next speaker, Dr. Andrea Wolf, is sharing an update from the IASLC Pleural Mesothelioma Staging Project, updated modeling of prognostic factors in pleural mesothelioma. She's director of the New York Mesothelioma Program, associate professor of thoracic surgery at the IACAN School of Medicine at Mount Sinai, and has expertise in surgery for pleural mesothelioma and VATS lobectomy, and research interests in mesothelioma, healthcare disparities, and lung cancer. She and her team at the New York Mesothelioma Program received the 2020 IASLC Cancer Care Team Award, and she received the 2022 Asbestos Disease Awareness Organization Irving J. Selikoff Award. She's presented at numerous national and international meetings, is co-editor of the 3rd edition of Sugar Baker's Adult Chest Surgery, and has published extensively on pleural mesothelioma and lung cancer. Thank you.
Thank you. First of all, good morning. Thank you to Chris Martin for organizing this, and to the press for your interest, and to my colleagues, especially Dusty, for your impressive work and these presentations this morning. I'm Andrea Wolf. I'm the director of the New York Mesothelioma Program and a thoracic surgeon in New York. I'm honored to present this work on behalf of my co-authors. By way of background, this work represents the sequel to the IASLC Staging and Prognostic Factors Committee previous project. In 2014, the mesothelioma domain published an analysis of the IASLC pleural mesothelioma database of cases diagnosed between 1995 and 2009, evaluating factors affecting prognosis. For the current project, we considered the previous work as a training data set of 3,101 patients, 65% of whom had undergone curative intent surgery. Our objective was to validate the previous models with the updated data set that better represented a real-world distribution of patients, more of whom were non-surgical, and then to improve on those models by evaluating the effect of adding additional clinically relevant variables. Toward this end, we used the more recent data set as a validation cohort. This included 1,733 patients diagnosed between 2009 and 2019, 47% of whom had undergone curative intent surgery. We performed Cox proportional hazards regression to evaluate the independent effect of the cofactors that were found to have a significant effect in the previous analysis. These were age, sex, histology, platelet count, white blood cell count, curative intent surgery, which included extrapleural pneumonectomy and extended pleurectomy decortication, and adjuvant therapy before or after surgery. For the current project, we added the variable anemia, defined as a hemoglobin of less than 11.5 grams per deciliter for women and less than 13.5 grams per deciliter for men. We also assessed the effect of mesothelin. We created a pathologic staging model, as well as a basic presentation model of all cofactors available prior to staging. The models were compared using Harrell's C index, which measures the probability that two randomly selected patients would have the same relative order of predicted survival times for a given model as those observed in real life. 0.5 is the same as chance. 0.7 is generally considered good. On univariate analysis, anemia was found to have a significant negative effect on survival. Likewise, high mesothelin was associated with worse survival, with a statistically derived cutoff of 6.7 nanomoles per liter. For the multivariable model, including all cofactors, non-epithelial histology, anemia, high platelet count, no adjuvant therapy, and higher stage were all independent predictors of worse survival. For the model of basic presentation, including all variables available prior to staging, non-epithelial histology, anemia, high platelet count, high mesothelin, and older age were all independently predictive of worse survival. Assessing model performance, the original training data set pathologic staging model resulted in a C index of 0.68, which is moderately prognostic. Using the validation cohort, the pathologic staging model resulted in a C index of 0.65, which is similar. Adding anemia, it resulted in a C index of 0.652. Although significant on univariate analysis, mesothelin was not independently associated with survival when adjusting for pathologic stage and other covariates. For a model of basic presentation prior to staging, as shown in the previous slides, the C index was 0.668, which was the highest we found. These were compared to the EORTC model, derived from a combined analysis of 5 phase 2 trials published in 1998. Using the validation cohort, the EORTC model resulted, including pathologic staging, it resulted in a C index of 0.550. For the basic presentation model, the EORTC C index was 0.577. Thus, the IASLC models performed relatively well in this updated validation data set, but clearly they have room for improvement. Anemia, when normalized to sex, is consistently a strong predictor of worse survival in pleural mesothelioma. We continue to stress the importance of standardized reporting of data through the IASLC registry, and the inclusion of additional appropriate molecular markers will likely improve these models. I can't stress enough the importance of upfront prognostic models, as inadequate staging and assessment may well have contributed to the negative clinical trial results we saw in MARS-2. So I want to thank you and thank my co-authors on the project and the members of the Staging and Prognostic Committee and the participating institutions, as well as the mesothelioma patients themselves. I'd also like to thank my team at the New York Mesothelioma Program and Mount Sinai for their outstanding patient care and support of our scientific efforts.
Thanks. That's such important and inspiring work. Thank you so much for sharing that with us. I'd now like to invite my radiation oncology colleague, Dr. Stephen Chun, to present results from his study, the NRG Oncology-RTOG 0617 study. He's presenting the 5 years results. Dr. Chun is an associate professor of radiation oncology at MD Anderson. He's responsible for leading the expansion of radiation oncology clinical trial program across the MD Anderson integrated satellite network, and is supported by grant funding for the NIH as a principal investigator. He's published in a lot of high impact journals such as the Lancet, the Journal of Clinical Oncology, JAMA Oncology, and the JTO, our own journal. Thank you.
Thank you very much, and good morning. I'd like to first thank the International Association for the Study of Lung Cancer Communications Committee for inviting me to speak about our study looking at long-term outcomes of intensity modulated radiotherapy for locally advanced lung cancer in RTOG 0617 at this press program. While definitive concurrent chemoradiation is a standard of care for unresectable, locally advanced non-small cell lung cancer, the optimal radiation technique is controversial, especially as intensity modulated radiotherapy is more costly and labor intensive than historic 3D conformal radiotherapy. Despite an early analysis of RTOG 0617 that suggested less pneumonitis in patients treated with IMRT, published in 2017, there is sparse long-term prospective data justifying the use of intensity-modulated radiotherapy, which better sculpts and conforms radiation doses to tumor than 3D conformal technique. So the purpose of this study was to compare long-term outcomes of radiation technique in a large prospective clinical trial. We hypothesized that intensity-modulated radiotherapy, because of its ability to shape dose better to tumors, would achieve superior long-term oncologic outcomes. This planned secondary analysis was based upon inherent stratification of RTOG 0617, where patients were treated at the discretion of the enrolling physician with either IMRT or 3D conformal radiotherapy. And because of the stratification, the allotment of the techniques were equally distributed in the 60 and 74 gray arms of the trial. We looked at long-term oncologic outcomes, long-term severe toxicity profile, and development of secondary malignancies. One of the key findings in this analysis was that intensity-modulated radiotherapy was associated with more than a twofold significant reduction in severe pneumonitis. Despite historic concerns of the low-dose bath, also known as the lung V5, spread by IMRT, there was no evidence that the lung V5 was associated with any kind of severe toxicity outcome. Another key finding in this analysis were the overall survival findings related to the multivariable analysis. On multivariable analysis of long-term survival, the heart V40 gray, also known as the amount of heart receiving 40 gray, was associated significantly with overall survival, and a heart V40 gray less than 20% was associated with much better survival than patients who had a heart V40 greater than 20%. As expected, the radiation dose level was associated significantly with survival, as was the tumor side. On the other hand, the low dose bath generated by intensity-modulated radiotherapy had no association with survival outcomes, nor did age when other factors were incorporated into this model. So in summary, this study represents the strongest evidence we will likely ever have justifying intensity-modulated radiotherapy for locally advanced non-small cell lung cancer, as a randomized trial directly comparing IMRT and 3D conformal technique is unlikely to be performed. We saw more than a twofold reduction in severe pneumonitis, and these findings corroborate the importance of using intensity-modulated radiotherapy for conformity to minimize intermediate risk doses to the lungs and intermediate and high-risk doses to the heart. We also validated a novel cardiac dose constraint, specifically the heart V40 gray, which should be constrained to less than 20%, which was validated rigorously in our multivariable analysis. Despite long-standing historical concerns about the low dose bath, we saw no association between long-term survival nor the severe toxicity profile with the lung V5. Similarly, intensity-modulated radiotherapy and 3D conformal radiotherapy had similar rates of secondary malignancy development over time. Taken together, these findings do not support lung V5 constraints, which inevitably degrade conformity. On multivariable analysis, age in of itself was not associated with adverse outcome. And for this reason, we really shouldn't be discriminating against patients purely on the basis of age in terms of candidacy for curative intent chemoradiation for locally advanced lung cancer. In closing, as I said last night during the presentation, IMRT should be used standardly for locally advanced lung cancer. Ladies and gentlemen of the press, we turned the page on 3D conformal radiotherapy for head and neck cancer, for prostate cancer, for brain cancer 20, 30 years ago, based, frankly, on far more flimsy evidence. This is strong evidence that intensity modulated radiotherapy, because of improvements in dosimetry, translates into better patient outcomes. It is time for us to turn the page on 3D conformal radiotherapy and accept the improvements in patient outcome that are afforded by the utilization of advanced radiation technologies like intensity modulated radiotherapy. So again, I'd like to thank the IASLC for this opportunity. The co-authors, especially Dr. Jeffrey Bradley, who's been a mentor of mine on this project, certainly the patients who participated in this trial, our funders from the National Cancer Institute and Eli Lilly, and thank you again.
Thank you so much. That's an incredibly important study. It's really going to underpin and transform modern radiation therapy practice across the world. So really, really impressive work. So lastly, yet incredibly importantly, we have Annabelle Gurwitch with us today, and she's a unique patient advocate. She is herself a New York Times bestselling author, actress, and activist. And her most recent collection of essays, You're Leaving When? Adventures in Downward Mobility, is a 2021 New York Times favorite book for healthy living, a Good Morning America must read, and a finalist for the Thurber Prize for American Humor Writing in 2022. She's written for the New Yorker, New York Times, Washington Post, Wall Street Journal, Los Angeles Times, and the list goes on, amongst other publications. And her 5 books include the New York Times bestseller and Thurber Prize finalist, I See You Made an Effort. She was a longtime co-host of the fan favorite Dinner and a Movie on TBS, a regular commentator on NPR, and her acting credits include Seinfeld, Murphy Brown, Boston Legal, and Dexter. She's been chronicling living with stage 4 lung cancer and inequities in healthcare in the New York Times and Washington Post since her out-of-the-blue diagnosis during COVID. And she's given patient advocate talks at scientific conferences around the world, including Vienna, Rome, and Brisbane. She co-hosts the podcast Tiny Victories, Please Go and Listen, which is dedicated to appreciating small mercies and minor triumphs on the Maximum Fun podcast network. Welcome, Annabelle.
Thank you, Fiona, and thank you everyone for being here. I'm Annabelle Gurwitch. I'm a writer and an actress, and as Fiona said, I was diagnosed with stage 4 lung cancer during COVID in 2020, and I am currently still in treatment for stage 4 lung cancer in Los Angeles. And this is my 3rd time at the World Conference. And I want to speak to 2 issues. Firstly, in terms of summarizing this panel, I think the best thing I can do is to say, I think this panel represents the unique tracks that this conference covers. We come together and we have data research that tells us about the pathway towards the future. And at the same time, we are understanding causes of lung cancer, which will help us to move forward in the future as well. And that is all, in some sense, supported by the patient advocate population who really wants to support in the same way that the doctors and caregivers support us. We are here to support this organization and the work they do, because not only is it keeping us alive, but we are all concerned about the future person who gets diagnosed with lung cancer. And by being here, we get exposed to the data and research that helps us to have better talking points and better understanding. I consider myself a C- science student. And even at that level, I was able to learn from Dr. Christian Rolfo from Mount Sinai yesterday about what some of the impediments are to immunotherapy being of use to stage 4 lung cancer EGFR patients. And that was really a triumph. And this speaks to, though, our being here as patient advocates, which Dusty has modeled so well, to the inclusiveness of this community. I think it's really unique in the medical establishment and in organizations that exist like this to have the patient's voice be so included and amplified. And Dr. Stephen Liu said something to me that I feel really speaks to this point. He said, you know, lung cancer has had such poor survival rates and outcomes in the past for patients that the people who have been drawn into working in the field of lung cancer have been particularly compassionate people. And I think that is the driving factor in including patient advocacy into the conferences and into the organization. And for the patient advocates, I think it's important to note that for many of us, we have such an improved quality of life and potential future, but we also live with a very uncertain future. And the patient advocate population who comes to be engaged in the conference and participate in IASLC, which I am following in the footsteps of people like Dusty, we're here not just for ourselves, and that really is a minor part of why we're here. We're here to advocate, as I said, for the next person who gets diagnosed with lung cancer and to learn to be better equipped in our advocacy. And I'm going to speak very quickly about the 4 things I think patient advocates have in common in terms of goals. One is funding. I think all of us patient advocates are dedicated to seeing funding equity, not only in our own countries, but across the globe. Secondly, legislative changes. By coming here to the conference, patient advocates get exposed to how legislative changes and policy changes across the globe internationally have been successful and sometimes less than successful. And we can use that knowledge to take home to our home countries to help see that implemented. Third, scientific knowledge. For me, it stretches my brain. Many of the STARS participants are much better versed in science. And by even understanding a little bit and understanding, I mean, I should say that with me, many people are, as I said, much better versed in the science. But by understanding and being able to understand the lexicon, which is so unfamiliar to us, as was said here, we didn't choose lung cancer. Lung cancer chose us. And so we've had to learn to speak the language so we can be more effective in our advocacy. And lastly, we have a unique opportunity here at the conference and through this organization to address survivorship issues with clinicians that we can't address in other settings. I have been fortunate enough to be able to continue working. I do spend a great deal of time every 3 months getting scans, being monitored, and in conversations and continually dealing with side effects and mitigating the issues that are related to living with stage 4 lung cancer. When I am in a clinical setting, I don't have the detachment to think about the larger issues that matter to me and matter to all the patients who are engaged in advocacy. It is such a fraught environment. There are so many stakes personally that I can't have the conversations that I want to have about where we can move this forward, where we can support clinicians and research, and where we can be useful to this organization. But here, separate from the clinic, when I'm not dressed in a hospital gown, and I don't have an IV line, I get to establish a human relationship and get to know the people and this incredible community. And it has been so valuable personally, and it has activated me to be a passionate advocate for all those large issues by being able to participate and by having our voice heard here. So I want to thank IASLC for the inclusiveness and thank everyone who's here on this panel, and Fiona and all of you for the work that you're continuing to do, and to Dusty and all the patient advocates who I learned from and inspire me to continue doing the work for the future. Thank you.
So thank you so much. And really, I can't say enough. It's just amazing what we've heard. We do have time for questions, so I'd like to open the floor to questions.
We have a couple of questions from online journalists. The first one's for Dusty. This is obviously an international forum, and your study looked at the United States, but for the people in other countries, what are the lessons that you can share with them about advocacy? Obviously, governments varied tremendously around the world, so not everything's going to work the same as it does in the United States. But what are some of the lessons that you can impart on other people that want to advocate for lung cancer funding?
Well, I think that, yes, as you said, every country and the government, the funding for research, I think it might be maybe one thing that we might have in common is that lung cancer research is underfunded. And we find that no one says they oppose lung cancer research funding or any kind of cancer research funding, but it doesn't mean much what they say if they don't fund it. So I think just everything is customizable to your own country and your own culture. Advocates, when I say advocates, I'm not talking about just like, as a survivor myself. That's why I became an advocate, but all of the researchers, they might not think of themselves as advocates, but they are advocates. And, clinicians, they are or should be advocates. So I think that's part of a role that all of us need to accept to advance lung cancer research funding. And it just has to be customized for their certain situation. I didn't understand the whole setup about Congress and how it worked for us to get increased funding, but now I do. And so, just in your own country, just if you can't advocate directly to your legislative body, then just using public relations, media, and sharing the stories of patients is an excellent way. You see those politicians really start to move when the headlines come out about people and their stories.
A question for Dr. Chun. You mentioned that IMRT has been accepted in treatment for other types of cancer. Do you see that changing more rapidly now with lung cancer because of some of your research and other colleagues?
I'd certainly hope so. I treat actually not just lung cancer in my practice. I treat other cancers, and this is how I'm aware of this. For something, as I mentioned, prostate cancer, head and neck cancer, gynecologic cancer, I would almost never have to justify to a third-party payer utilization of the technology. It's just been accepted. And I do hope that its acceptance by both physicians and by third-party payers will improve as a result of work like this. But I think that remains to be seen.
See, he's an advocate. He's an advocate. I see that.
One final question for Annabelle. How can the lung cancer community work better with Hollywood to get its message out?
How can the lung cancer community work better in Hollywood? Well, I think that's a difficult question. One of the things I've tried to address myself, and why I went public in the New York Times and in the Washington Post and the writing that I'm doing, is the stigma against lung cancer that we've seen exist globally, and trying to break that stigma, because for many people, they don't come forward. And so identifying as someone in treatment for lung cancer, I think, is the first step. I wanted to say one thing about what you mentioned about Dusty's work in terms of getting legislative movement. I think when you come to a conference like this and you see modeling, what you get is modeling for how to attack issues and take that back to your own country. One of the things I've learned from Dr. Benjamin Besset in France is how how the system was able to institute biomarker testing across the population. Now, they've done that in very specific ways that I think can be modeled in the United States. You know, in the United States, we have huge biomarker testing inequity. And so by looking at the French model, I can take that information back to the United States and use my platform and my writing to suggest and posit models we can work with. And I'm currently working on legislative efforts in California representing 75 NGOs towards that effort. So we use, I think, modeling is one of the most important ways we learn and we get empowered as activists, and also why we have information sharing in the medical community as well.
Are there any other questions here in the audience? Okay, thank you.
Thank you all so much. Thank you for sharing your time and coming to hear us, but also thank you to our wonderful panel for their generosity and their honesty and their enormous dedication and hard work. Thank you.
Thank you.